Thank you for joining. This is the Uniform Data System UDS reporting prep for 2022. The presentation will begin in just a moment. Everybody is in listen only mode, and you will receive a recording afterwards that will be sent out in an email to everyone. And as you see, there's a question box on the bottom corner of your menu. Go ahead and submit any questions during the presentation. Hopefully we will have time to get to those by the end of the presentation. If there's not enough time, we will make sure to follow up with you afterwards. So don't hesitate to submit those. All right, next slide. All right, about eMed apps. It looks like we were missing our social media slides. So just as a reminder, you guys can follow us on all of our social media platforms. We're on Instagram, we are on Facebook, we are on, I believe, Twitter as well. And then we also have a YouTube channel. So just go out there and search eMed apps. All right, about eMed apps. We are a healthcare information technology services company providing practices, clinics, and hospitals with a full range of services, as well as a suite of products that are designed to increase efficiency and facilitate communication. We were founded in 1999. We have been working as a partner with NextGen since 2001. We work as a subcontractor for NextGen. We serve healthcare clients all across the USA, and our services, and we have services and products for NextGen clients. We also have some services and products for other EHRs as well. Oh, there we go. There's our follow us on all our platforms. All right, about our presenters today. We have Mary Min here, who has been with us since 2006. She's a senior application analyst and has over 30 years experience in healthcare. Our other presenter is Vicki Rawanski. She has been with eMed Apps since 2013. She's a senior solutions specialist and has over 30 years as well experience in healthcare. So thank you, Vicki and Mary. I'll give it over to you.
Good morning. Thanks for joining our UDS preparation webinar. We're going to go over some items today to give you a little bit of a heads up and help you prepare for your reporting that will come around in January. We're going to be talking about where your data actually comes from, troubleshooting your results, and give you some preventative measures and best practice in order for you to have a smooth UDS reporting process. So where does your data come from? I'm going to review areas within the NextGen application specific to where the NextGen UDS tool pulls its data from. There are a few steps needed for your qualifying encounter. So what makes a qualifying encounter? A qualifying encounter is an encounter where the service is rendered qualify for our UDS reporting. There are a few steps in order to understand how NextGen calls or creates an encounter as qualifying. The very first step is to identify whether the service item itself or the service is considered a qualified service. This determines made in the service item library, and there's three checkbox in a drop-down. That's kind of the drop-down is in the newer versions for self-pay qualifying, sliding fee qualifying, and qualifying encounter for all payers. So if our service item or service that's being rendered does qualify under the UDS guidelines, we want to make sure that all three of these checkboxes are selected when you are adding new SIMs. So once we've identified what service items qualify for a qualified encounter, from the front end of the application, NextGen requires your encounter to be in a build process. So the process of actually building your encounter will trigger the box to identify that this is an encounter, the qualified encounter. This can be found in your encounter maintenance screen under your claims and your general tab, and it's a checkbox that gets flagged when you bill for FQHC qualifying encounter. So on your provider type for your financials, for your Table 5 staffing and utilization, the NextGen tool will count encounters by provider type. This field is located in your provider master file under the practice tab. The NextGen tool does require that all provider types be mapped, even if you don't have any providers on staff for certain types. You can add additional provider types to your master list. And then once you do that, they are available to map in the tool. So even if you don't have providers of certain specialties, you can still map those. There just won't be any data associated to it. And it will ease your mapping in your NextGen tool. How do I handle non-billable providers? So there are 5, NextGen gives you 5 generic licenses for different provider types: nurses, dental aides or assistants, other mental health staff, other vision care staff, and enabling services. So for our 5, for our non-billable types, we should have generic providers set up for each one of those if you provide those services. And they should all be, each one of those should be utilizing a provider type associated with the list down below, so that you can capture those, all of those encounters for the UDS reporting. On table 4, principal third-party medical insurance comes from the patient demographics on the UDS tab in the primary medical coverage dropdown. This should always be populated. It should be a required field with either selecting a payer or with utilizing the self-pay checkbox. It's important to note that this should be medical coverage only. So if you have other types of services for dental or vision, you want to make sure that this is utilized for primary medical coverage only. And this should be verified every time a patient is checked in. As patients' medical services can change, you want to make sure that this field gets updated regularly. So managing, understanding your data with your NextGen tool itself. So NextGen in the NextGen tool console allows for filtering of your data by letting us have inclusions and exclusions. Inclusions would be practices, locations, or providers. It's not uncommon to have locations or providers that you do not wish to report on. You also may have practices that you might want to leave out of your UDS tool. So this is done by simply checking all the boxes that you want to be included in the report. You want to make sure that once you've selected those, that you save your changes. And on your exclusions, so CPTs and patients are available for exclusions. Oftentimes clinics have dummy codes that they use for internal reporting needs, and they don't want these reported in the UDS report. So you can select your service items that you wish to not include. So by default, everything is included. So all service items will be included unless you've selected them on this exclusion list. Also, all of your test patients should be excluded from your UDS report. You can simply match on any word, or depending on your naming convention for your test patients, you can just type it in there and hit search, and you can select all of your test patients to make sure that they are excluded from that UDS reporting. Once you've excluded them, you should see all of your excluded patients and or codes. You should be able to see in the center white screen once you've saved it.
Thanks, Mary. Now let's review Table 6A, selected diagnoses and services rendered. So in the UDS tool, codes are sent and updated through the cloud automatically. Any custom codes need to be added. For example, you've added additional SIMs or CPTs for state grants. You'll also want to add these codes and account for them in any custom reports or third-party applications. To add or modify a code in this area, you just want to go from the code mapping on the top button, and then select the custom 6A codes on the left navigation, select the mapping type and category, and then enter your range. Okay, the link here directs you to the HRSA table of all the new line items and codes, and it will shows you the specific changes for this reporting here. Okay. Table 6B and 7, quality of care measures. This reporting area is dependent on LOINCs and SNOMEDs besides CPT and diagnosis codes. Okay. And so why LOINC and SNOMEDs? This is used for consistency, for interchange. If we don't have that embedded into our minds already after a few years, the LOINC is related for specific for standard lab and radiology, and then SNOMEDs provide for consistent terminology for electronic interchange. CMS does require specific coding for quality measures, and obviously failing to map items may result in misreporting. Okay. In our NextGen application of file maintenance, you can see our order tests and order components are cross-mapped with LOIN codes. So we have a lab test on the left and a radiology test on the right, and both of those are associated with a LOIN code. And then our order components for typically like a CBC, we want those component tests mapped also to a LOIN code. Okay, so you may ask yourself, how do I map missing items, or why do I need to, since I've done it already in the past years? It's always good to be sure and not have any missing data. We're so dependent on data other than our own. Lab and radiology entities have downtime. You may also have downtime. There's manual entry involved. So a few of those tools to update the mappings, one is a quality measure data tool. This will assist in mapping file maintenance and NextGen templates. One item, it should be ran after hours. And then, okay. Once it's downloaded, the tool comes with 3 specific spreadsheets, 2 lab vendors and 1 radiology. You want to open up these spreadsheets and review the mappings, make your changes, or go ahead, next slide. Yeah. Or if you don't use these lab vendors, you'll want to identify one of the sheets as your vendor. So for instance, you're going to take the LabCorp or the Quest spreadsheet, make your changes, and then once the tool brings that specific spreadsheet data into it, you're going to specifically map it to your other lab. So for instance, Orchard or SunQuest. So for the example here, we're actually mapping the LabCorp LOIN compendium to the SunQuest because we identified that spreadsheet with our SunQuest labs. And this is just an example. If you on radiology, the same goes with the radiology one. You just want to, again, update that spreadsheet and then map it to the file maintenance in the order test. The following SQL, if you're SQL savvy, you can run these 2 statements and it will show you the updates that you just did from the quality measure data tool. Next, yeah, there is another tool. It's the NCS LOINC utility, and this has been around a little bit longer than the quality measure data tool. This will actually map your order test and component results. So this is your items coming back from the lab entity. So what's better? Well, the preferred is the quality measure data tool. However, I still like to do both as I want to be sure my data is entirely accounted for on all measures. Okay. The next uniform code is SNOMED. So there are a few system practice templates also used to map these codes besides being hard-coded in template triggers. So one example, if you add any additional referral specialties, you'll want to add these in the custom DB pick list template and then assign the specific qualifier 1 SNOMED code. Okay, troubleshooting, always fun. So the following was and still is the specifications for running the UDS tool. Now, if your requirements were enhanced already, you should still check and monitor and ensure you're with the guidelines and thresholds. For instance, you were between the 500 and 1 terabyte at one point, but now maybe after a year, you've moved on to the next level. So you just want to make sure that your hardware items are still at the, the specific NextGen specifications. Okay.
Thank you, Vicki. So we'd like to make some table clarifications, just so that we know everybody understands how the UDS tool works. So table 3A is our unduplicated count of patients. So NextGen uses birth sex field to identify sex assigned at birth. The UDS tool only pulls patients if the sex is male or female. If any other option is selected in that drop down, those patients will be excluded from the UDS report, even if they have qualified encounters. So you want to make sure that you understand that if you have undifferentiated or unknown or any other option in that list, you're going to want to take a look at those and make sure that those get updated. This is just a reminder for your qualified encounters that you do not report encounters for screenings, tests, or vaccines. Those do not qualify. And also, HRSA wants to make sure that virtual and telehealth visits, make sure you're following the HRSA guidelines, not state and local requirements. We know that we have multiple different requirements at the local level, so HRSA just wants a reminder to say, follow our guidelines, please don't follow the local ones. Now, balancing your tables. It's important to make sure that we everything is logical when we're reporting it on our UDS report. So balancing our tables, table 3A, 3B, and 4, they are all the same list of patients. They're just different looks at the patient characteristics. So these tables should all be equal to each other. Balancing tables for table 4, your unduplicated patients by third-party payer. Again, this is a demographic field. It's only one field. It's only reported once, so you want to make sure you keep it updated. And again, those numbers should match. Now, table 413A through C, this is the only field where you might be counting patients that didn't have a qualified visit during your reporting year. So these are your capitated members and your fee-for-service members. They want your member months. So you will have patients, or you very likely could have patients and member months in this field where they didn't actually even come in and have any qualified services. Table 5, it's important, should not balance to your table 3. Patients that are seen multiple times in the year with different provider types will be counted under each category. So we would typically see that these table 5 numbers should not, they'll be higher than your table 3A.
Thanks, Mary. Table 6A and 6B. These tables cannot be compared to each other. There's between the two different time periods, calendar year versus a look back year. For example, colorectal cancer, breast cancer, cervical cancer, all look back many years. The ages are very specific, and the measured time period changes. So for instance, preventative care and screening tobacco went from 24 to 12 months this year. So all those measure changes we would like to, or we need to review and make sure that the report is adequate. Okay. Table 6A range verification. So when using the tool, ensure your code range is consistent as the tool gets updated and importing past values. There's many inconsistent range values. We've had many troubleshooting over the year on this specific issue. There's staff changeover. Staff entered it one way, and then new staff will enter it a different way. So you can see by this example, we have different range values for the disease. Does it really matter? Maybe not, but we just want to make sure it's all consistent. So what I like to do is, oh, please go back up. Yep. What I like to do is export out the values into Excel or use the SQL code here I provided and run that and then review your values. Okay, let's go on to table 9D. 9D activation. So for last year's reporting, this table was made unavailable. So if for any reason you did need to enable it, you can force it to show through SQL, which is listed here. However, we've been told that this will probably not be able to be in the new version. So be proactive and have a plan on where to retrieve this information. Mary, do you have any insight on where to retrieve this information in NextGen?
This will be it'll be your front end financial reports. We don't generally make too many recommendations given that everybody's got different structures. A lot of this information is based on custom terminology and whatnot. So yeah, if you're not sure, you can always reach out to us. But I would recommend also comparing your data maybe that you pulled out of 9D the prior year, and you can map that from the front end application reporting.
Thank you. Okay. So customizations, are all your custom codes accounted for? So we have some different 6A codes coming in. We have changes with our quality measures. The best practice is to use standard coding. However, some individual states or grant reporting, we want to create those one-off codes. Make sure those are also part of any value sets and third-party applications. For custom reporting, I try not to hard code any values in. I usually use a lookup table, or I don't use descriptions, as those can always be changed. And don't forget, some of the measures go back some years, so remember ICD-9s may still be required. Troubleshooting new CQM and measures in general. Next slide. So definitely we had some heavy troubleshooting on these two particular new measures between the tool and looking at our charting. So breast cancer screening, it's actually reduced to LOINC codes. So we want to make sure that those LOINC codes are mapped and that we go back to historical data. So that's that quality measure data tool or the NCS LOINC utility. And then HIV screening is a lifetime look back. So this can be difficult coming from paper or a conversion from a no chart abstraction. So they do have a generic LOINC code for you to use and to assign that, but these are going to be definitely I think another troubleshooting issue this year to look at the documentation. So now, as I looked at my table numbers and they don't seem accurate, what should I do? First, you want to check the application SQL Cloud for errors in the tool. What are the errors? Are they specific to my table I'm having issues with? So are all value sets accounted for? I've upgraded to a new version. Do I need to do a reset, and why? So we've had measure changes, new measures added, errors in cloud updates, qualifying encounter updates that we fixed, and we flagged those new, the encounter as a qualifying encounter, or some other major data changes. How do I, again, how do I find my last repository refresh date? So the following SQL here will show you, and again, if you're SQL savvy or go to your IT group, this will show you how to retrieve the last repository refresh date. So now with that, so how do I do a reset? In the application of the UDS tool, you'll want to navigate over to admin options and maintenance tasks. Within this list of stored procedure names, you'll want to go through the following process. One, clear out any old automation scheduled tasks. So if you have any hung reports out there, this will clear those out. And then two, clear out historical data. This will remove all any of the detailed report data from your filter sets. Just be sure to export that out, or that it's exported out already, so that you can compare those reports with the new set running. And then three, will clear out all repository tables and force a reload of your UDS warehouse. And then you'll want to, number four, this was pertinent to this past reporting cycle. I don't know if this will be part of the new version, but we did have to reset the UDS table sections because that breast cancer and HIV screening was added as a new section under the main line items. So then you'll want to reset your Windows service, run your ad hoc report, and then you're going to force it by number 6. You're going to force that first time automation so that you don't have to wait Saturday morning at 2 o'clock. Okay. Some preventative measures and best practices. So Mary, what are some preventative measures?
So some things we'd like to recommend. Ensure that your annual ICD-10 and your CPTs are up to date. So we're looking at October 1st. ICD-10s are available, so we make sure that those updates get ran as soon as you can possibly get them into your system. Your CPTs will be active. You'll have new CPTs as of January 1. So you want to make sure that you have a process in place so that those are imported, in a timely manner. We recommend that you create and run memorized reports to validate your data mappings. I will go through that here just in a moment. Please don't wait until the end of the year to start reviewing your SIM libraries. Review this quarterly to make sure that your codes are marked appropriately as qualifying encounters. Remember, the trigger for that is billing your encounters. So if you make any updates to your corrections in your SIM library, it's not going to update the historical data. You're going to need to do that in a manual process. Review again your billed encounters quarterly to make sure that those items are marked correctly and that your encounters are flagged appropriately. Believe it or not, we do have many clients who, they run this at the end of the year, and it ends up that they have all kinds of encounters either marked inappropriately or that they're just missing data, missing encounters. So it definitely helps to run this on a quarterly basis. And then put in a process for adding your new SIMs to your SIM library, and when you're adding your providers, make sure that everybody, whoever is responsible for adding these items, understand the UDS importance from some of the fields that you have to populate. So validate your UDS tool mapping and filters in the beginning of the year. So if you want to make sure your tool is up to date, that your mappings are current, and check for any missing mappings if there are any. All new lab orders need to have a LOINC code attached. And then balance your results. So balance the tool results to your system reports and address any inconsistencies. Start poking around to see what might not be set up right, or what might not be right prior to the year end, so that again you're addressing that, whether it's a workflow issue or whether it's just updating flags within the NextGen application. And then lastly, review last year's HRSA results with what you're looking at this year. If there's any major changes, you're going to be asked to explain or why, identify why you have a fluctuation in some of your data. So either you know why there's a reason, you had additional providers or lack of providers, or you don't know what the reason is, and that's where your troubleshooting and review needs to come into place. For reporting on your provider type. So create and memorize a provider type report. This report is in file maintenance, and it will help you quickly identify any providers that might be missing this provider type field or might be listed inaccurately. Create and memorize your service item library. This is we're looking for qualified SIMs. Verify that all SIMs are marked, that they have all 3 checkboxes selected, and that all qualified SIMs are in fact selected. Also, you want to look on the other side of that. Make sure that you don't have any service items marked qualifying that in fact are not. Make sure you have, again, a process in place for SIM ads. And make sure that they understand that these how and when these boxes should be selected. From the practice management system, run and memorize encounters report. I like to look at all encounters for the year, and I review, and I usually review them by what's qualified, the qualified encounter indicator. You want to make sure you're looking at both sets so that you're nothing that is marked as qualifying is inaccurate. And then also, making sure that anything that you've got that is not qualifying today, that's accurate, so that you know if you're going to be missing any data. We recommend running these reports prior to even running your tool, so that it prevents it prevents you from having to run those reports in the tool multiple times. So these are a good way to run it ahead of time before you even run your UDS console reports. Now, birth sex. Qualified encounter flag can be updated as issues are identified. If you have anything within SQL, if you have multiple encounters. Sorry, I was on the next slide. If you have multiple encounters where you found major issues or issues that just impacted large numbers of encounters, you may have somebody internally update those for you from the SQL side, on the back side. Okay, so on your birth sex. So you want to review, again, we want to make sure this is something that could slip right onto the radar, because there's no real nothing that's going to pop out to you if patients, a particular patient might not be included. So if you want, you can run and create, memorize a patient chart demographics report. And you can say, I selected, because that's an incredibly data intensive report, you can go to your filter to tab and pull up sex code and say, show me anything between O and U. That's a way to pull out just the patients that you want to look at and update, as opposed to looking at your entire patient history, all your patient charts. So that's something that if you create and memorize these reports, you can create a report folder for UDS reporting. Just make it a process to run all of them quarterly and keep all of your data updated on a regular, basis.
Thanks, Mary. In addition, there's the Orders Management Council. You want to review and run this routinely. At a minimum, I would say every 3 months, every quarter. If not, put it into as part of your maintenance schedule, along with your quality measure data tool and your LOINC utility. In the chatter group, if you belong to the UDS and the new releases, they will indicate when there's updates for any of these items for the NextGen Compendium, the LOINCs, or for Lab or Quest. Okay. Some additional prevention is ensuring your medications maintain your updates. This is where your RX norms and your NDCs come from, so that when your clinical staff do the prescribings, the updated coding is on those medications, in which then the quality measures extract from. And I can't express more is training, training, and more training. I know we love this word, but you can't just train once and um, don't train again. It's just we got to make sure the best practice workflow is implemented. And then these two following links are for NextGen's best practice workflows on where they extract the clinical quality measures from. And then be proactive, not reactive. So as Mary was explaining earlier, it's running the reports, checking the data, good, garbage in, garbage out, things like that. So just be proactive. I know we always try to be proactive. It's not a reality in life, but as much as if we can get to that 80 to 90%, it'd be great. Some of the proposed changes and resources coming along. NextGen's 2021 NextGen tool updates. They plan for a November release. It's maybe a cloud. I know they've been insinuating it's going to be just cloud updates, so the base structure the application is going to stay intact. However, they did indicate that a full install could be necessary again this year, which then we go back to doing that data reset, which I went over earlier in the PowerPoint. There's going to be some table 6B and 7 fixes on the measures, and then naming conventions are going to be aligned more with HRSA. Their hospice exclusions will be enacted. The HIV linkage to care will be updated from 90 to 30 days. And then they're doing some work on the SDOH and loading the prepare assessment. And then table 9D will be removed entirely, we've been told. So there is no flag to show it. So the slide previously is only for the current version now. Again, we'll have to see what comes in November. Some of the 2022 in the next reporting quality measure change, this just lists out the CMS measures that will be changed to, and then the link to those changes. And then we have some additional resources here for you, either going to the HRSA site or the NextGen community. The last one is for the value sets on the ECQM. So if you have any data warehouses, any lookup tables, any reports, you want to review that to make sure your custom reporting is updated and you're looking for the new coding. Okay.
All right, I do have a few questions that have been sent over. First of all, what constitutes the universe of the report?
Okay, so Vicki and I had been talking about this because this always comes up again in our troubleshooting. And so the UDS, the universe for the UDS tool is going to be any patient with a qualifying encounter. So if your patient is, if you have a patient and they're one of your on the unduplicated patient list, all of their history should be included as part of the universal reported into the UDS tool.
I would agree with that. And then on in addition to that, the universe could be, okay, there's two steps to that universe. So you have your patient population, And then the next step would be your exclusions from that patient population. So we have to look at, with the quality measures, the exclusion then thereafter. So we're looking at qualifying encounters and then also your exclusions from your denominator.
Okay. Next question. Okay, I think you covered this a little bit. You went over the steps for the reset, but I got asked, is there a UDS tool update yet?
Not until November. That's what NextGen is communicating to us. So just
November of this year?
yeah, November this year, and it's usually around UGM. So it's been like that for I want to say the past 15 years. They like to push that out around there. So I'm expecting definitely by the end of November. And I did hear that it will probably not be a beta this year. So normally we can get through a beta, and some of the health centers can be beta active and test it out, but that they're still on the fence about that.
Okay. And then the next question, what makes it a qualifying encounter?
Again, so we did go over that a little bit. A qualifying encounter is a visit that has a service item where that's a qualified service, and it's been put through the billing process. It's at least in a billed status.
Okay. Then the next question, when will table 9D be removed from the utility?
Not until actually once you upgrade to the new version or they send over the new update in cloud. So I'm thinking November, as long as you're on version 4.0, it will still be there.
And if you're concerned, if you have historically been dependent on that table, I would recommend running the enabling it now in your tool. Run your data, even if it's just for 6 months or 10 months or however many months you're completed, and then use that information as a mapping tool from the front end of your application to get out the reports that you want. And that'll keep you at least consistent with what your prior year reporting was if you used their table 90 last year.
Yeah, that's great, Mary.
All right, and then the next question, why am I not getting data under certain provider types?
So if you're not getting data under certain provider types, most likely you don't have, well, either one, you don't have that provider type, you're not providing those types of service, or in your provider master file, you don't have the appropriate provider type selected. So the tool does require you there. It's kind of a catch. I know we've struggled for the last couple of years. It does require you to map all provider types that UDS has, wants to know about. And when you don't have those particular types, people get stuck on whether or not to, how do I map something that I don't even have? So you can, in your master list, again, make sure that you have all the UDS reportable provider types. Make sure you have those in your list, in your master file list, and then that'll give you the option to map, do a one-to-one mapping in the tool. So even if your provider, you don't have those providers, you can still map it and get past that piece of it in the tool so you can run your reports. In addition to that, there could be a variable where you have a certain provider that, or type of provider that maybe falls into more than one UDS reporting category. And again, if that's the case, you can also map a provider type by CPT code. It is pretty intensive. You've got to have really good coding within your practice management system, as well as a really good understanding of what they do in order to map it, but that is also an option.
Okay, any more questions? We do have a little bit of time left, so please go ahead and submit those. Looks like it's gotten quiet. And I just want to thank everybody for attending today. We do appreciate your time and hope that these webinars are helpful for you. You will be sent out an email that has a link to the webinar recording. It will have a separate link to the PowerPoint. So you will get both of those. Usually it comes out within about a day or two. Automatically from the GoToWebinar. Feel free to reach out with us if you have any other questions or need additional assistance in this area or other areas. We're always here to help. You can go to our website, give us a call at our phone number, or if you know your rep in your area, feel free to reach out to them directly. So again, thank you for your time and hope everybody has a great day. Oh, one more question came in. Is all billable encounters fall under fully qualified?
No, so those are two, the term is used kind of, they cross-reference that quite a bit within NextGen, but a billable encounter is reference to the financial facing side of the application. So there are services that could be billable that are not, our tests and whatnot. Those are we can bill for those, but those are not qualified encounters. So they wouldn't qualify all by themselves unless there was a, another service item associated with it. So those two are not synonymous to each other.
Good questions. Thank you. Again, before we sign off, does anybody have anything else they'd like us to answer for you? All righty. Thank you again, everybody. Have a great day and a great rest of your week.
Thank you.
Thank you.